Have you ever stopped to think about all the incredible things your body does without you even lifting a finger? It's like we're all walking around with this amazing biological autopilot, and today we're going to pop the hood and see exactly how it works. So here's how we're going to break it down. First, we'll look at the autopilot system itself. Then we'll explore the two opposing forces that keep everything in balance, kind of like a seesaw. After that, we'll zoom way in on the body's wiring, take a quick tour of the command center, the brain, and wrap it all up with a super handy cheat sheet so you won't forget a thing.
All right, let's jump right in. Section 1, the body's autopilot. This is all about the behind-the-scenes magic, the system that keeps you alive and running every single second of the day. No conscious thought required.
I mean, think about it for a second. You're not sitting there telling your heart, okay, beat faster now, or telling your hands, all right, guys, time to get sweaty. These things, they just happen, right? So what's pulling the levers? Who's in charge here?
Well, the answer is this incredible thing called the autonomic nervous system, or the ANS for short. This is the master controller for basically everything you don't consciously manage. Its one and only goal? To keep your internal world perfectly balanced, a state called homeostasis, no matter what chaos is going on around you.
So moving on to Section 2. Now, the ANS isn't just one simple on-off switch. It's much cooler than that. The best way to think about it is like a seesaw, with two different systems constantly working to balance each other out.
And these are the two players on that seesaw. On one side, we've got the parasympathetic system. This is your rest and digest mode. Think of it as your chill-out button. And on the other side, you've got the sympathetic system, which you've probably heard of. It's the famous fight or flight response that gets you all amped up and ready for action.
So let's say you've just finished a huge, delicious meal. You're relaxed, you're chilling on the couch. That's when your parasympathetic system takes the lead. It slows down your heart rate, tells your digestive system to get to work, and basically handles all the body's housekeeping. It's all about conserving energy. And the key chemical messenger making this happen is acetylcholine.
But then, suddenly, you hear a loud noise, or you remember you have that huge presentation tomorrow. The seesaw tips. The sympathetic system slams into gear. Your heart starts pounding, your breathing gets faster, and your body stops worrying about digesting lunch, because let's be honest, that's not a priority when you're facing a threat. Your pupils even get wider to let in more light, making you more aware. It's all about survival.
And here's the most important takeaway, the golden rule. These two systems can't be in charge at the same time. They are total opposites. When fight or flight is on, rest and digest is off. It's this beautiful, dynamic balance that lets your body react perfectly to whatever life throws at it.
Okay, so we know what the systems do, but how do these messages get around so fast? For that, we need to zoom way in. It's time to meet the high-speed messengers of the nervous system, the neurons.
So, a neuron is the basic building block, the individual wire that makes up your entire nervous system. Its whole job is to zap information all over your body at incredible speeds, using this amazing combination of electricity and chemistry.
And every signal follows a specific route. Think of it like a tiny relay race. The message gets picked up by the dendrites, the cell body figures out what to do with it, and then, whoosh, it shoots down this long cable called the axon. That axon is wrapped in something called a myelin sheath, which is like the rubber insulation on an electrical cord. It makes the signal super duper fast. Finally, the message reaches the end and gets passed on to the next cell in line.
Now, why are we getting so into the weeds on this? Because this structure is absolutely critical. In diseases like multiple sclerosis, that myelin sheath, that crucial insulation, gets damaged. And without it, those nerve signals can slow to a crawl or just stop altogether. It just goes to show you how important every single part of this tiny system really is.
Okay, we've seen the systems, we've seen the wiring, now let's go to headquarters. It's time for a lightning-fast tour of the command center that runs the whole show, your brain. So at the very top level, you can kind of split the brain into three big zones. You've got the forebrain, which handles all the complex stuff like thinking and feeling. Then there's the midbrain, which is like a busy relay station for movement and senses. And then you have the hindbrain, which takes care of the absolute must-have functions that keep you alive.
Now, if we zoom in on the forebrain, we find even more specialized departments. The frontal lobe, that's basically the CEO. It handles your personality and decision-making. The temporal lobe is your audio department, processing everything you hear. And way in the back, the occipital lobe is 100% dedicated to vision. Every part has its own specific job.
But let's circle back to that hindbrain for just a second. We've got to talk about the medulla. This little part is the unsung hero of your entire body. It controls your breathing and your heart rate,
the absolute bedrock of survival. It's so important that any damage here can be catastrophic, which tells you everything you need to know about its job. Whew! Okay, we have covered a lot of ground. So for our last section, let's just lock it all in with a rapid-fire review. This is your ultimate cheat sheet for your nervous system. Let's make this super simple. If you see signs of chilling out, like a lower heart rate and more digestion, you know you're looking at the parasympathetic system. If you see signs of high alert, a racing heart, wide pupils, that's your sympathetic system, no question. Hear about myelin damage? Your brain should immediately go to multiple sclerosis. And who's in charge of breathing and heart rate? That's the medulla, tucked away in the hindbrain. See? It's a great little shortcut.
And we'll leave you with this final thought to chew on. We've just mapped out this incredibly complex automatic biological machine. So what does it truly mean that our thoughts, our stress, our meditations, that all of that can reach in and actually influence this entire system, from the command center all the way down to our pulse? It's a pretty powerful connection, isn't it?
All right, today we're going to tackle a really complex and fascinating condition, multiple sclerosis. This is a case where the body's own defense system basically goes rogue. So let's break down what's really going on inside the body when this happens.
To really get a handle on MS, we have to start with this one central question. It's almost like a medical mystery. What happens when the very system that's designed to be your bodyguard, your immune system, gets confused and starts attacking you instead?
And that question leads us right here, into what is fundamentally an autoimmune mystery. It's a classic case of mistaken identity, where the body's own defenses become the aggressors.
So at its core, multiple sclerosis, or MS, is a chronic, long-term autoimmune disease. And what that means, in simple terms, is that the immune system gets its wires crossed and mistakenly targets the central nervous system. We're talking about the brain and the spinal cord, literally the command center for your entire body. So yeah, you can think of it as a case of friendly fire on the most critical network you've got.
Now, MS isn't always a constant, steady progression. For most people, it follows what's called a relapsing-remitting pattern. This means they experience flare-ups, relapses, where symptoms suddenly get worse, but then they're followed by periods of recovery or remission where symptoms might actually improve or even disappear for a while. So we know what's being attacked, the central nervous system. But how does this attack actually work? Well, it all comes down to a very specific target, myelin. The key to this whole thing is the myelin sheath. The best way to picture it is like the plastic insulation around an electrical wire. Its job is to protect that nerve fiber and help the electrical signals just zoom along, super fast and efficient. So you can imagine, without it, those signals get all scrambled and disrupted. So this brings us to the process of demyelination. Here's how it goes down. First, the immune system launches its attack. Second, the myelin gets damaged and destroyed, and as a result of that, the nerve signal, the message from your brain, either slows way, way down, or it just stops completely. Over time, this repeated damage leads to scar tissue forming, which doctors call plaques, and these plaques are, for all intents and purposes, roadblocks on the information superhighway of your nervous system.
So with all this damage happening on the inside, what kind of evidence does it leave behind? Let's do a little detective work and follow the symptom clues, which are really just the external signs of this internal fight.
Now, here's a really important thing to get. The symptoms of MS can feel incredibly varied and all over the place, but they aren't random. They actually tend to group together in what we can call symptom clusters, and that helps us make a lot more sense of them. Let's look at some of these clusters. In the vision cluster, a classic sign is optic neuritis, which causes blurred vision. For sensory, you're talking about numbness or that pins and needles feeling. Motor symptoms can be things like muscle weakness and serious balance problems. And a huge one is systemic fatigue. And this isn't just being tired, it's an overwhelming exhaustion that can get worse throughout the day. The big picture is that the symptoms directly map to where the nerve damage is happening. The location of the attack determines the evidence. So how do doctors confirm all this? Well, they look for the physical evidence. The telltale sign, the smoking gun for MS, is finding those areas of scar tissue we mentioned, the plaques. They show up very clearly on an MRI scan, and they are the key piece of evidence needed to make a diagnosis. Here's a really useful rule of thumb. It's almost like a shortcut that doctors use. If you have a young adult who shows up with a combination of neurological symptoms and that deep, profound fatigue we talked about,
Well, multiple sclerosis should be way up on the list of possibilities. It's just a classic combination. So, once the diagnosis is made, the focus totally shifts from identifying the problem to actively managing the condition day to day. So what does that actually look like?
And this is a really important mindset shift. You see, right now, there isn't a cure for MS. So the main goal of treatment isn't a cure, it's to manage the symptoms, slow down the disease, and, maybe most importantly, improve the person's quality of life. It shifts the focus from a single win to a long-term strategic campaign for well-being.
Yeah, managing MS takes a comprehensive, multi-pronged approach. It's not just one thing. It involves strategies for managing that crushing fatigue, like pacing your activities. There's physical therapy to improve strength, psychosocial support for mental well-being, and of course, powerful medications called disease-modifying therapies that can help slow everything down.
Out of all those strategies, one really stands out as a top priority: safety. I mean, think about it. Because MS can cause major balance issues and vertigo, just preventing falls becomes absolutely critical. It's about keeping people safe and helping them maintain their independence. So if you're going to take just one thing away from this whole explainer, let it be this simple formula. MS is an autoimmune disease, which leads to the myelin being destroyed, which causes nerve signals to slow down. That's it. That is the core of the entire mystery. Solved.
And that leaves us with one final thought to chew on. MS really shows us this fascinating paradox, that our own body is both our greatest protector and, sometimes, our greatest adversary. So how does knowing that change the way we think about health, wellness, and what it even means to heal? It's something to think about. Thanks for joining me.
All right, today we're tackling something really interesting. What happens when the body's central command system goes haywire? We're going to look at two major conditions, one that's a slow, creeping decline, and another that's a sudden, catastrophic break. Let's decode what that really means for how we move, function, and live.
So, let's start with the big question. What actually happens when those critical signals from your brain to your body get interrupted? One involves a signal that's fading out from inside the brain itself, while the other is like a physical cut in the communication line. Let's get into it. So on one side, you've got Parkinson's disease, which is a progressive degeneration. You can think of it like the volume knob on a radio, being slowly, relentlessly turned down. The signal just gets weaker and weaker. But on the other side, you have a spinal cord injury, or SCI. That's like someone taking a pair of scissors and just snipping the cable. It's a sudden, total disconnect. Two very different pathways to a massive disruption. Okay, so first, let's dive into Parkinson's. This one's a real puzzle when it comes to controlling movement.
So what's the deal with Parkinson's? Well, it all comes down to a chemical called dopamine. Your brain has these little factories that produce it, and dopamine is what makes our movements smooth and coordinated. In Parkinson's, those dopamine factories start shutting down, and as they do, the ability to control your muscles starts to fail.
So how does this actually show up in a person? Well, there are 4 classic or cardinal signs. First, there's a tremor, the shaking that often starts in one hand when it's just resting. Then you have rigidity, which is just stiff muscles. But the two I really want you to lock in on are bradykinesia, that's a hallmark slowing down of all movement, and postural instability, which means poor balance and a really high risk of falls.
And what's fascinating is you can literally see how those internal problems create this classic external look. That postural instability, it's why you often see that forward-leaning posture. The bradykinesia, that slowness, causes that shuffling walk with tiny little steps. The rigidity can even affect the facial muscles, which leads to what's called a mask-like or blank expression. Even the voice can become very soft and monotone.
So when you put all of that together, what's the number one priority? It's safety, right? With the poor balance, the slow movements, that shuffling gait, the risk of falling is just huge. So the absolute top priority is preventing those falls and doing everything possible to help that person stay independent for as long as they can.
All right, let's totally switch gears now. We're going from that slow fade to a sudden, traumatic break. We're talking about spinal cord injuries.
Now, this is completely different from Parkinson's. We're not talking about a chemical problem here. A spinal cord injury is all about physical damage, maybe from a car accident, a fall, or something else. That spinal cord, the superhighway for all the body's nerve signals, gets damaged, and that crucial communication link between the brain and the body is either broken or severely messed up.
Okay, this next part is super important to understand about spinal cord injuries. There isn't just one injury, there are actually two phases. The first is the primary injury. That's the moment of impact, the initial physical damage. But then, the body's own response kicks into overdrive, and that causes a secondary injury. This massive wave of inflammation and swelling can actually cause even more damage over the next few hours and days. It's just a brutal 1-2 punch.
And that brings us to maybe the single most important point about SCIs. It's not just that you have an injury, it's where the injury is. Knowing the level of the injury isn't just something you need to know for a test. It is absolutely critical for keeping a patient alive.
And this table shows you exactly why that's so true. Just look at the connection here. If an injury is way up high in the neck at the C1 to C3 level, boom, it knocks out the nerves that control breathing completely. The priority there is mechanical ventilation, immediately. A little lower, at C3 to C5, you have some function, but breathing is super weak. The priority is airway support. The rule is simple. The higher up the injury, the bigger the impact on the ability to breathe.
Okay, we've looked at two really different kinds of neurological disruption. So let's boil this all down to the key takeaways. Think of these as your "if you see this, you think that" cheat codes. Okay, scenario 1. You walk in and you see a patient with that resting tremor. They're moving really, really slowly, and they have that classic shuffling walk. What's the first thing that should pop into your head? Parkinson's disease. Exactly. Those are the big 3 signs that point right to that dopamine problem we were talking about.
All right, scenario 2. A patient comes in after a traumatic accident. You know they have a high spinal cord injury, somewhere up in the neck, from C1 to C5. What is the one thing you have to think about before anything else?
Airway. That's it. Your number 1 priority. Period. Before you do anything else, you have to make sure that patient can breathe. And that really brings it all home, right? Whether it's a slow chemical fade or a sudden physical break, if you understand the core problem, you know exactly what matters most. All right, today we are tackling a medical emergency where literally every single second matters. We're going to break down exactly what happens during a stroke and why those first few hours are so incredibly important for a person's chances. Let's just dive right in.
You know, you often hear a stroke called a brain attack, and that's exactly what it is. It's sudden, it's brutal, and it's life-changing. So the core question is, what is actually happening when the brain's blood supply just gets cut off? The answer to that question is what makes this a frantic race against the clock.
So here's our game plan. We'll kick things off with the basics, what a stroke actually is. Then we'll get into the critical difference between the two main types. From there, we'll cover the race against time treatment, how you can spot the signs, and wrap up with essential patient care. Let's get started.
All right, Section 1, what is a stroke? Before we can even talk about symptoms or treatments, we have to get a handle on the basic science of what's going on inside the brain during one of these events. So at its heart, a stroke is basically a plumbing problem. See, blood carries all the good stuff, oxygen, nutrients, and when that supply line gets choked off, brain cells start to starve. And without that fuel, they get injured. And then, really fast, they start to die. Moving on to Section 2, the critical distinction. Now listen up, because this is probably the single most important idea to wrap your head around. Not all strokes are created equal. They fall into 2 totally different buckets, a blockage versus a bleed. And figuring out which one it is, that's the first and most important step.
Okay, so check this out. On one side, you've got your ischemic stroke. This is the one you see most often. Just think of a blocked pipe. A blood clot gets jammed in an artery and nothing can get through. Then on the other side, you have a hemorrhagic stroke. This is more like a burst pipe. A blood vessel actually breaks open and starts bleeding out into the brain. So blockage or bleed. Simple difference, but it changes everything.
And that leads us to a really big question, right? I mean, a blocked pipe is obviously bad, but why is a burst pipe, a bleed, so uniquely dangerous when it happens inside our head?
Well, the answer really comes down to basic physics. Your skull is a hard, sealed box. There's no extra room in there. So when a blood vessel bursts and starts bleeding, all that blood has nowhere to go. The pressure just builds and builds, and it can literally start to push the brain out of place. It's a terrifying thing called a midline shift, and it is a massive, life-threatening emergency.
Section 3, a race against time. Okay, so now we know the 2 types. Let's look at what happens next. This is where the clock starts ticking, really, really loud. This phase is an all-out sprint, because when we're talking about the brain, every single second counts.
So before anyone makes a single move, before any treatment is decided, this has to happen. An immediate non-contrast CT scan of the head. Why? Because it is the fastest, clearest way to answer that one crucial question. Is this a blockage or is this a bleed? Everything that follows depends on that answer.
Now, if that CT scan shows a blockage, an ischemic stroke, we have this incredible tool we can use called TPA. The easiest way to think about it is like a super-powered clot-busting drain cleaner for the arteries in the brain. It's a drug designed to do one thing: dissolve that clot and get the blood flowing again. But, and this is a huge but, you can't just give TPA to anybody. There's a really strict checklist. First, the CT scan absolutely has to confirm it's a blockage, not a bleed. Second, you have to be in a super tight time window. We're talking just 3 to maybe 4.5 hours from when the symptoms started. And that's determined by step 3. You have to figure out the last known well time, the absolute last moment anyone saw that person acting totally normal. I'm going to say this again because it is so important. If you're a student, write this down, it's going to be on the test. If you're in the real world, this is a life or death fact. TPA is only, and I mean only, for ischemic stroke.
And this right here shows you exactly why. Giving a clot-busting drug to someone who's already bleeding inside that sealed box of a skull, it's like throwing gasoline on a fire. You would take a terrible situation and make it catastrophically worse. And that's why we always do the CT scan first. No exceptions.
Okay, section 4, spotting the signs fast. You know, all these amazing medical treatments don't mean a thing if the person doesn't get to the hospital in time. So, how can you, just a regular person, know when to make that 911 call? Well, thankfully, there's a really simple acronym that can help you save a life.
You just have to remember, be fast. B is for balance. Is there a sudden loss of coordination? E is for eyes. Any sudden vision changes? F is for face. Ask them to smile. Do you see a droop on one side? A is for arm. Is one arm suddenly weak or numb? S is for speech. Is it slurred or just weird? And if you see any of those things, T is for time. It's time to call for help right now. Now, that brings up something called a TIA, or a mini stroke. This is a tricky one. It's when someone gets those be fast symptoms, but then, after a few minutes, they just go away. The blockage was just temporary, and everything seems to go back to normal.
But, and please hear this, a TIA is not a get-out-of-jail-free card. It is a massive warning sign. It's like the brain is screaming at you that there's a big problem with the plumbing and a huge, permanent stroke could be just around the corner. A TIA is a full-blown medical emergency. You still go to the hospital.
Okay, and for our last section, let's talk about essential patient care. So, once the patient is in the hospital and that immediate crisis is being managed, the focus starts to shift a little bit. Let's look at the key priorities, especially from a nursing point of view.
Really, it's all about watching them like a hawk. You're doing constant neurological checks, checking their level of consciousness, their strength. You're keeping a super close eye on their vital signs, especially blood pressure. And 2 huge ones. You're assessing their risk for aspiration, that's choking on food or water, and you're making sure they're safe from falls because they're often weak or unsteady.
But out of all of those things, what is the absolute #1 top safety priority for a patient who was just admitted with a stroke?
This is it. You keep them in PO, nothing by mouth. A stroke can easily damage the nerves that control swallowing, a condition called dysphagia, and that means they could choke on anything you give them. So no food, no water, not even their oral meds, until a speech therapist comes and does a proper swallow evaluation to make sure it's safe.
Okay, so let's do a super quick recap. Key takeaways. Number 1, ischemic is a clot, hemorrhagic is a bleed. 2, the CT scan is what tells you the difference and decides everything. 3, TPA is the clot buster, but only for clots and only within that tight time window. 4, use be fast to spot the signs. And 5, never ever blow off a TIA. It is a critical warning.
Which leaves us with one last thing to think about. We know the saying is, time is brain. Every minute that ticks by, more brain is lost forever. So the real question for all of us is, how can we do a better job of educating everyone to recognize that T and B fast and act on it immediately? Something to think about. Thanks so much for watching.
All right, today we're jumping right into the deep end with 2 of the most critical situations you can face in medicine: seizures and traumatic brain injuries. In these moments, every single second counts, and knowing what to do can literally change a person's life. So let's get right to it.
So, picture this. You're on the scene,
and a patient suddenly goes rigid and starts convulsing. What's your first move? What's your immediate priority? Answering that question correctly is everything. So we're going to break down exactly what's happening and what you need to do. First up, seizures. The best way to think about this is like a sudden, chaotic electrical storm inside the brain. It's just a complete overload. And to get a handle on it, you first have to understand what's actually sparking that storm.
So at its most basic level, a seizure is kind of like a short circuit. See, your brain is all about balance. You've got signals that say go, those are excitatory, and signals that say stop, which are inhibitory. A seizure happens when that balance gets totally thrown out of whack and you get way too much go signal. All those neurons start firing like crazy, and that's the chaos you see on the outside.
So what causes this imbalance? Well, it can be a whole bunch of things. Sometimes it's a big underlying problem like a genetic condition, a tumor, or damage from a stroke. But other times, it can be something more immediate. Things like extreme stress, not sleeping for days, or even flashing lights in someone who's susceptible can be just enough to trigger that electrical overload.
Now here's where things get really dangerous. What happens when that storm just doesn't stop? That is a condition called status epilepticus, and it's not just a long seizure, it's a continuous state of seizing. And this is the point where the situation flips from a serious problem to an absolute life-threatening emergency. And this brings us to the most important number you need to remember, 5 minutes. The second a seizure crosses that 5-minute mark, you are officially in status epilepticus. The brain is being starved of oxygen, and the risk of permanent brain damage, or worse, is climbing with every single tick of the clock. You've heard it before, but it's never been more true. Time is brain.
Okay, so we get the problem. We understand the danger. Now for the action plan. What do you do when you're the one standing there?
Your priorities are actually pretty simple, but they are non-negotiable. First, protect them from injury. Get them down to the floor safely and move anything hard or sharp out of the way. Second, time it. As soon as it starts, look at your watch or pull out your phone. That 5-minute clock is ticking, and the doctors need to know. And third, watch their airway. Just observe their breathing. Make sure nothing is blocking it.
Now, I have to pause here for a massive mythbuster. We've all seen it in the movies, right? Someone tries to shove a wallet or a spoon in the person's mouth. Let me be perfectly clear. Do not do this. Ever. You are so much more likely to break their teeth, cause a choking hazard, or injure their jaw than you are to help. Just don't.
Okay, so the seizing stops. Your job is not done. The very first thing you do is gently roll them onto their side. This is the recovery position. It uses gravity to make sure any saliva or vomit drains out of their mouth, not down into their lungs. This is also your moment to check vitals, and, this is a big one, check their blood sugar. Sometimes, a simple case of low blood sugar, hypoglycemia, can be the hidden culprit behind the whole event.
All right, let's switch gears. We're moving from an internal electrical storm to a physical attack from the outside, traumatic brain injury, or TBI. What's wild is that a bad TBI can actually cause a seizure. But the real sneaky danger with a TBI often shows up hours or even days after the initial hit. You really have to think of a TBI as happening in 2 waves. The first wave is the primary injury. That's the moment of impact itself. The bruises, the bleeding, the direct damage. But it's often the second wave, the secondary injury, that's even more deadly. This is the brain's reaction to the trauma, all the swelling, the inflammation, and the rising pressure inside the skull that can cause way more damage than the initial hit ever did.
And that gets us to the core danger here. Your skull is a hard, fixed box. It doesn't stretch. So when the brain inside starts to swell, it has nowhere to go. This creates what we call increased intracranial pressure, or ICP. It literally starts to crush the brain tissue and choke off the blood supply. And if it gets bad enough, it can physically shove the brain to one side, an absolutely catastrophic event called a midline shift.
So how in the world do you spot this building pressure before it's too late? Well, you have to become a detective. You have to learn how to read the body's warning signs, the clues that tell you a TBI is escalating into a full-blown crisis.
2 of the most terrifying signs are these postures. On the left, you've got decorticate posturing. The easy way to remember this is that the arms flex in toward the core of the body. This is a very serious sign. But what you see on the right, decerebrate posturing, is even worse. The arms extend out stiffly like the letter E. This tells you the damage is likely very deep,
down to the brainstem, and the prognosis is, well, it's much, much worse. Okay, we have covered a massive amount of high-stakes information, so let's take a second and lock in the most important high-yield takeaways that you absolutely need to have on instant recall when things go bad.
Let's make this super simple. This is your cheat sheet. If you see a seizure blast past that 5-minute mark, your brain should scream status epilepticus. If you see anyone even think about putting something in the patient's mouth, you think wrong and you stop them. See those stiff, extended arms after head trauma? That's decerebrate posturing, and that is a very, very bad sign. And finally, any patient you have with a known TBI, your mind has to be constantly focused on one thing, monitoring for that rising intracranial pressure.
So there you have it. We've broken it all down, from the 5-minute rule for seizures to the ominous signs of a TBI. The knowledge is officially in your hands now. So the only question left is, when the moment comes and the pressure is on, are you going to be ready to act?